on the rest of our programs coming up. And perfect timing.
Perfect
Yay.
timing. Thanks for the gracious introduction. It's nice to see everybody here. I've given these talks now probably at least once or twice a year for the past several years, and these are some of my favorite talks to give because people that are here because they want to be, because they want to learn and they want to get some information, and they take their time out of their day to actually make it to these talks, and I like them because they're kind of cozy. It's just us, and we can make this relatively informal where if there's any questions at any point, please chime up. I'd like these to be more sort of discussions, and I like this to sort of serve as more of a platform for the discussion. And every now and then we pick different topics to talk about, and this is a topic that I'm particularly interested in. Oh, thank you. And this is a topic that I think is going to be getting more and more traction over the next coming years, because this is a cancer that has probably touched many of our lives, if not personally, then through someone that we know. And unfortunately, as we'll see here, this is also a cancer that's becoming more frequently, and it's a cancer that we still have a lot of work to do with. I just had a show of hands. Does anybody here have any family members or friends who've been sort of dealt with pancreatic cancer? Okay, so it's something that when you see it, especially in a loved one, and you see the toll that it can take, it's a really an eye-opening experience, and I hope to sort of shed a little bit of light into what pancreatic cancer is. What are some of the things that we're doing to diagnose it or pick it up? What are some of the signs that we can find in ourselves with pancreatic cancer? I want to talk about what we're doing to try and treat it, where we have room to grow, and also talk about maybe potentially some things that we can do to try and prevent it. So that's what we'll kind of, whisk through here in the next, 30 minutes or so. So you may recognize some of these people, okay? And all these people have something in common. Given that my talk is about pancreatic cancer, all right, it's likely going to be pancreatic cancer. So Patrick Swayze, a lot of familiar faces here. Does anybody know who this is? Pavarotti, right? So it's the guy in Die Hard and also in the Harry Potter movies. Okay, I don't remember his name. Aretha Franklin, Bill Gates, Ruth Ginsburg, all Alex Trebek. Pancreatic cancer has affected these celebrities, and this is just sort of a list. And I've been making this. I have this list. I've been giving this talk for years, and unfortunately, each year I kind of add a picture. And so I when I was giving this talk to my grand rounds over at Christ, I felt like this was my pancreatic cancer hit list, and so hopefully it doesn't get any bigger than
Who's
this.
the guy in the center on the top? Who's that?
Right here?
No, in the center.
Oh, right here?
Yeah.
That's Alex Trebek from Jeopardy.
Oh.
Yep.
Okay.
Yep. I think it was just last year that he passed from pancreatic cancer. Very sad. He fought,
Almost 2 years ago, I think.
was it longer than that? Yeah. He fought very hard, unfortunately.
Streets and all that stuff.
Right. So let's see if this moves forward. So here are just kind of some numbers. So pancreatic cancer in 2021, there was about 60,000 new cases of pancreatic cancer and about roughly estimated 48,000 deaths from pancreatic cancer. Unfortunately, pancreatic cancer's incidence, meaning the number of times we're diagnosing it, is actually increasing. Not only that, but as opposed to some other cancers, the rate of mortality or the rate of death from it is actually going up too, which is a little bit different than some of our other cancers. And it's projected by the year 2030 that pancreatic cancer is going to be the #2 cause of cancer death in the country. So it's going to surpass breast cancer. It's going to suppress breast cancer and be right below lung in terms of some of the most lethal cancers that we have out there.
Is there a reason why it's increasing as opposed to all the others?
That's a good question. There are a couple of reasons why we think that it's increasing. One of the big causes has to do with the obesity epidemic that's going on. There's a link between insulin resistance, obesity, new onset diabetes, and pancreatic cancer. In the past, smoking used to be the biggest driving force for pancreatic cancer. And we're seeing now, as our smoking rates have gone down, but our obesity rates are going up, that obesity is playing a big role as a risk factor, as opposed to some of our other, risk factors. The other issue that is felt to be a risk factor is our diets and our high sugar diets. This doesn't necessarily only apply to pancreatic cancer. We're seeing it also correlate with other cancers like colon cancer, but with some of our increasing numbers of diabetic patients, increasing number of sort of people who are on sort of high sugar diets, the obesity pandemic. And there's more and more pancreatic diseases. We'll talk in a little bit here about what chronic pancreatitis means, which means scar tissue to the pancreas and how that forms. And that's also another risk factor. So there's more of this in play, but there's also factors we just don't understand as to why it's going up. Now, why is it, becoming more lethal? Why are more people dying from it? We'll kind of hit upon that here in just a little bit, but part of it has to do with the fact that this is a largely silent cancer. By the time you develop symptoms, it's usually advanced and it's usually a little bit too late. We also don't have as effective treatments for this cancer as opposed to some of our other cancers. And so that's why it's also increasing in its lethality. We don't have good screening tests. So there are some other cancers out there like colon cancer, breast cancer, that have actual screening programs which are very effective in reducing the rate of actually getting the cancer. We don't have that for pancreatic cancer. So all of these together are contributing to some of this, these sort of ugly numbers, and unfortunately have more ugly numbers as we go around. So what's the average age of diagnosis? Roughly around 70. Okay, so this is tends to be a disease of later ages, but just like in colon cancer, we're starting to see an increasing incidence in our younger people, in the age 50s, 60s. And again, I think that's part of some of the things that we mentioned, maybe correlating with some of our dietary and lifestyle changes. And so now we're seeing almost, a quarter of our patients being diagnosed roughly in their 50s. Like, again, I just hit upon, more than half of the patients that we're diagnosing with pancreatic cancer, we're picking it up at an advanced stage. So when that patient comes to me in the office and we're looking and concerned about pancreatic cancer, and we make that first diagnosis, half the time the disease has already spread. As you guys know, with any cancer, the earlier the cancer, the better we are at treating it. That goes across the board for almost every cancer, every malignancy. And it's especially important with pancreatic cancer. And so with pancreatic cancer, the later that we pick it up, the far less likely we are going to do a good job at treating it. So this pie graph here just shows us that this sort of kind of lime colored slice is the percentage of patients that show up at the door who already have metastatic disease, meaning their cancer has already spread. This graph over here shows us the 5-year survival for patients with pancreatic cancer, depending on if they were diagnosed with early disease, which is this dark green here, versus metastatic or advanced disease. So this is 5-year survival. This percentage tells us what percentage of these patients are alive in 5 years. So for patients with metastatic disease, advanced disease, only 3% of those patients are with us 5 years from the time of diagnosis. For patients with early cancer, which we call here localized, at 5 years, maybe half, which is still a very bad number, right? So this is a graph that really sort of pushed me to be interested in pancreatic cancer, because this is clearly something that we have a lot of work to do on. Just let's kind of know our enemy, right? Let's talk a little bit about the pancreas, just to kind of get an idea of this actual organ system. Many of us go throughout our lives not really quite knowing what the pancreas does, or where it is, even for that matter. So the pancreas is a digestive organ, okay? It's an organ that's actually closer to your back than it is to your front of your abdomen. So it's a deep, what we call retroperitoneal organ. And it's sort of up high. It's kind of right below your breastbone. And it sits in a very busy area of the abdomen. So it's very closely involved with the first part of your small intestine. So this is your pancreas right here. This is called your duodenum, which is the first part of your small intestine just past your stomach. Now, in this diagram here, your stomach is actually right above all this. So it kind of sits right behind your stomach. Here, they just took out the stomach so you can see what's behind it. The pancreas, just like us, it has a head, it has a neck, and a body, and a tail. The tail end of the pancreas goes all the way to the left side of your abdomen, and it sort of touches around your spleen. It sits above your kidney. And you've got some major vessels that course right behind it, like your aorta and some of your major veins. And so this is a very vascular tumor. So it's got a lot of blood flow, blood supply, a lot of things around it. This is kind of more on the back side. And again, I just wanted to highlight how much blood vessels come to the pancreas. And this perfusion, or this vascularity to the pancreas, is part of the reason that pancreatic cancer spreads so quickly. So if a tumor starts in the pancreas, generally, the way it gets to other organs and other sites is either through the blood vessels or through the lymphatics, which are kind of like a drainage pipe. And so when an organ is very highly vascularized, it's really easy for a tumor to get into one of those vessels, and some what we call micrometastasis spread, and then that's where it can start going to some other organ systems. The other reason I put this diagram in here is this green tube, which is really important. We'll come back to that later. That's called the bile duct. That's the duct that drains bile from the liver, okay? And that's essentially a very, very important structure, and something that we'll talk about here in terms of symptoms.
A question.
Yeah.
Is the pancreas only feeding in like digestive juices or whatever into the small intestine? Or
It
is
is.
it doing to many different?
It goes directly into the small intestine.
That's
and
the main linkage.
it's the only linkage predominantly for digestion. And that's actually a perfect segue into the next slide, which is sort of what the pancreas does.
Okay.
And it's a digestive organ. So it helps us on one end through what's called an endocrine function by making or helping us with insulin production, right? So insulin is really important for how we get our sugars, It's important for how we metabolize our glucose, okay? And so insulin is a really important product of the pancreas. The other function of the pancreas is with digestive enzymes. These are the enzymes that break down our food, break down our proteins, break down our fats, and they have names like lipase, amylase, trypsinogen. This is in the juice of the pancreas, which goes into the pancreatic duct, empties out into our intestine, mixes with our food, and helps us digest our food. Without these enzymes, we can't digest a big portion of what we eat. And so that makes us malnourished, and that gives us diarrhea and makes us lose weight. And so the pancreas is an essential organ, for digestion. And that all goes through this little duct in the middle of the pancreas and empties out through a tiny little opening about the size of the tip of a pencil, just past your stomach, where it mixes with your food. So that's what the pancreas looks like. That's where it sits in our body, and this is what it does. All right.
Does it deal with hormones as well?
Well, actually, yes. And so, the pancreas is very responsive to hormones. There are certain hormones that are released through other parts of our, body, like, for example, the stomach and parts of the small intestine that actually trigger the pancreas to release some of these enzymes. So that it's all sort of correlated in there. All right, so what are some things that we might see in our friends and ourselves and our family members that could raise the possibility of there being a pancreas problem going on? So here are some of the symptoms of pancreatic cancer. And I'd like to point out that, again, in early pancreatic cancer, a lot of times there are no symptoms. And we'll talk about how some of those patients kind of show up. But if there are symptoms occurring, One of the most common things that you'll see is jaundice. Jaundice means yellowing, okay? Many of you are familiar with that. Yellowing can occur in a couple of different scenarios. And I'll go back to that slide in just a second. But this is jaundice. So, this picture kind of cut off a little bit here, but this gentleman over here has yellow skin. This is his actual twin brother here who does not have yellow skin. This is just kind of comparing the skin. So it's usually your whole skin turns yellow. The first places that you will see this jaundice are actually though in your eyes, in the whites of your eyes, they'll turn yellow. The second most common place that you will see jaundice is actually in your urine, okay? So your urine will turn from a sort of more of a clear yellow into more of a darker color. And that some people compare it to tea or a coffee colored urine. It's normal when we wake up in the morning for our urine to be a little darker than usual because it's concentrated. Throughout the night, your urine gets concentrated. Our bodies do that, so we're not waking up all the time to go pee. So that's normal. But what with patients who have jaundice, this discoloration persists, and it's usually pretty remarkable. Patients will notice, whoa, that's a little odd. And so that's one of the first things we'll see, followed by the change around the eyes, underneath the tongue, and then finally the skin. And why is this jaundice occurring in pancreatic cancer? Well, it's because of that very important bile duct that I mentioned. So this is a picture of a tumor in the head of the pancreas. And because that bile duct, the transport duct of bile from the gallbladder and the liver pass right through the pancreas, that can block that bile duct. And when that bile duct gets blocked, that bile has nowhere to go, and it sort of spills out into your bloodstream and into your body. And that's the source of this jaundice, is that greenish yellow bile spilling out of the duct because it's blocked. And so this symptom will only occur if the tumor is in the head of the pancreas where that bile duct is. And so the patients that present early with pancreatic cancer are the patients that tend to have a tumor in the head of the pancreas because it actually causes a symptom that we can see, which is jaundice. Let me go back here. So we talked about dark urine. Okay, so clay-colored stools. So, all right, sorry for the graphic image here, but no GI talk is complete without a picture of stool. So this is what something called steatorrhea is, which is a type of a stool that occurs when you have a deficiency in your pancreas enzymes. It turns oily. You see oil droplets, it's frothy, floats, and oftentimes it'll be a very pale color. This one, doesn't apply too much to this particular diagram, but it'll be clay colored or pale. So that's another red flag symptom. If you see that, or if you know somebody who has a clay colored pale stool, that could be a sign of a blockage of the bile duct, and that in part could be due to a tumor. Pain. Pain is usually upper abdominal pain. It's a boring type pain, and it tends to, but not always, radiate towards your upper back. Again, because the pancreas is a retroperitoneal organ, or organ that's closer to the back. This pain is sometimes worse after eating and sometimes worse when you're lying down on your back, but it's a pain that's constant. It's not something that is going to sort of occur once in a blue moon. Some people present with just isolated back pain, upper back pain. That always scared me because I always get aches in my back, and now every time I'm like, oh my gosh, it's this pancreatic cancer, because everybody gets back pain. And this is a back pain, again, that's going to be isolated upper, and it's going to be usually associated with something up front, but these are how some patients present. Weight loss. Weight loss applies to any cancer. Cancers are very hypermetabolic. They break down energy and nutrients, and they cause you to lose weight. And so whenever someone has weight loss that's unexplained, it always needs to be addressed by your doctor. So this could be a sign of pancreatic cancer because of the cancer itself, but also, like we talked about, those digestive enzymes stop working as well. And so you're not digesting your food, so you're losing weight, in addition to the cancer itself breaking down some energy. We talked about the stools. And then this is a kind of a newer one, or very important, which is new onset diabetes. If somebody develops diabetes after the age of 50, and is associated with some of these other, things like weight loss, that's could be a potential sign of pancreatic cancer. And again, that has a lot to do with the fact that the pancreas makes insulin, which is part of the problem with diabetes, okay? So these are really the main symptoms that you can show up with pancreatic cancer. The diabetes that we talked about, patients who are above the age of 50 who develop new onset diabetes, they have an 8-fold higher chance of developing pancreatic cancer. And now we're paying very special interest to these patients who get diagnosed with diabetes after the age of 50. It's sort of forcing us to take a step back and make sure, in addition to treating their sugar, hey, make sure let's address your pancreas. Let's take a peek at your pancreas or make sure everything is okay. And so that's something that's really important and something that can potentially be impactful in our primary care practices. Very briefly, I'll just go over some other ways pancreatic cancer can show up. This is, in my experience, the most common way, which is by accident. Someone comes in because they have kidney stones. Someone comes in because they got appendicitis or they have some belly pain. Nowadays, you walk into the ER, first thing you're going to get is a CT scan, okay? Even if you're just asking directions, okay? They're going to get you a scan. And a lot of times they're picking up these scans, they're picking up growths in the pancreas. And so that's a good thing on one end, because a lot of times if they're picking it up before symptoms develop, we're catching it a little bit early. And so this is a CAT scan, and where it's circled here, this is your pancreas. There's a growth there that the radiologist sort of picked up. There are other things that can cause sort of growths in the pancreas, like scar tissue from prior inflammation. But in general, any growth in the pancreas is cancer until proven otherwise. The other way that pancreatic cancer shows up for us is people that also have a scan and we just see that their drainage pipes, that bile duct that we talked about, or that pancreas duct, look big. They look like they're expanded, like they're dilated. That could be another sign for us to take a look at the pancreas. And then there's the patient who keeps getting pancreatitis. Are you guys familiar with pancreatitis? Pancreatitis, it means inflammation to your pancreas. We hear it most often with our drinkers, our heavy drinkers. They get, bad pain because the alcohol sort of irritates their pancreas and it gets inflamed. So when you have an inflamed pancreas, it's called pancreatitis. Very painful. They come into the hospital, usually need fluids and medicines and things like that. But some people get this pancreatitis even though they're not drinking, and no other causes of pancreatitis. And sometimes that could be because they actually have a small tumor in their pancreas that's causing the pancreatitis. So if you know anybody who keeps getting pancreatitis and they're not sure why, that's a reason that they should talk to their doctor about taking a closer look at their pancreas.
What's the white, with the pancreas pointed out there, and what's the white on the bottom portion of it?
Right here?
Right below the pancreas, on the left side of the pancreas. There's right there. What is that with the white right there?
This is a very important blood vessel here. So this is called the splenic artery. Okay,
So it's not part of the pancreas.
no, it's one of those big vessels that kind of sit around the pancreas. Yeah.
Okay.
But again, that's why when the pancreas is involved, a lot of times these vessels around it will be involved too. And we'll hit upon that here too. So once we're suspecting pancreatic cancer, what now? Let's say we have those symptoms, or let's say we have a suspicion that we're concerned about maybe there's cancer of the pancreas. What can we do to confirm or rule it out, right? What should we ask our doctor for? What can our doctor be looking to do? Well, these are the main tests on this side of the screen that we use to diagnose pancreatic cancer. Usually the first thing, am I blocking your view, by the way? I just realized that I'm right over here. Okay. So the first thing is usually going to be a CT scan. Okay. That's usually the first test that we can get to take a look at the pancreas. And that's going to be good for kind of big things, big growths. It's not the best for smaller growths. Okay. An MRI is also very good at looking at the pancreas. It's got more detail than a CT scan, but it's a little bit more expensive. And sometimes MRIs, I don't know if anyone's ever been in an MRI, like, if you're claustrophobic, it's no fun, you know, and so they're also costly. But that's another option or that we have in our armamentarium. The big player here is this. This is sort of the reason I'm giving this talk, is because that's something I do. It's what's called endoscopic ultrasound. So endoscopic ultrasound is sort of now kind of the gold standard test for taking a look at the pancreas and anything around the pancreas. And it's pretty neat. I'll show you here, and I'll go back in just a second. It's a pretty neat test. So it's a scope, just like a scope that you guys have had before, colonoscopies or upper scopes. The only difference with the scope is it has an ultrasound probe on the tip of it. So the thought being, well, if we're down in your stomach and your pancreas sits just a few inches away from your stomach, we can get a much better view than when we're looking through your skin and fat tissue and muscle and everything else. If we're putting our probe right, above the pancreas and the stomach, we get really good views. And that's why we can see the pancreas to details of about 2 millimeters. So the endoscopic ultrasound can find even the smallest of tumors. But more importantly, it also allows us to take a biopsy. And so with the same device that shows us the tumor under ultrasound, we can stick a very thin needle, it's called a fine needle, and take a sample. So this is just an example of the ultrasound, what a tumor looks like on the ultrasound. I know this might look like just some static on an old TV, but this dark little area here underneath the probe is where the tumor is. And pancreatic cancers are notoriously difficult to see. They're not as easy as sometimes, lung cancers or tumors elsewhere. The tumors in the pancreas can be very sneaky. They can be very difficult to discern from the surrounding tissue. And so that's why CT scans are not 100%, and even MRIs are not 100%. And even this endoscopic ultrasound, it's not 100%, although it's 96%. So it's pretty high.
So the scope goes down in your stomach,
Exactly right. Yeah. So
and then the needle would go through the stomach to reach the pancreas.
exactly right. Yep. And I had a diagram, but I don't think it's going to play, but it's exactly right. So we're down with the scope, you're sedated. We get IV medicine just like for a colonoscopy or an upper endoscopy. And then we go down and then we get a view just like this, using the ultrasound, and we can see directly where the mass is. And under real time, we pass that thin needle directly through the stomach wall into the mass. And because it's so close, it's relatively easy and accurate to do. We can avoid big blood vessels and other ductal structures.
Is there something that's done more known than it was, let's say, 10 years ago?
Absolutely, absolutely.
Okay.
So this is a relatively new or newer tool that we have. And so it requires special training. So you have to do, in addition to your internal medicine and then your general GI fellowship, you have to do a specialty. They just want to keep us in school for as long as they can, and to do that.
Right.
And how invasive is that? And the side effects or whatever, as far as the person doing the procedure, is it pretty high tech, or is it more?
Yeah,
You know what I
no,
mean? You know what I'm saying?
absolutely. No, it's not invasive in the sense where there's no cutting involved. It's not a surgery. It's the same sort of invasiveness as, say, a colonoscopy, although it doesn't require bowel preparation and things like that. So the risks are exceptionally low. The risks are things like bleeding. Anytime you have a biopsy anywhere, there's a small risk of bleeding, infection. With the endoscopic ultrasound, those risks are actually lower than any other form of biopsy through the skin. And that's the nice thing about it. So it's one of our safest ways to actually get tissue. You have to get sedation, so there's always risk with sedation, and so you'd always get assessed by your gastroenterologist to make sure it's a safe approach, to do a scope. But if you're healthy enough to get a colonoscopy or an upper scope for, say, reflux, you're going to be healthy enough to get an endoscopic ultrasound.
And then when it's over, because it goes down to your throat, right?
Exactly, it goes
So
down like
itching or soreness or
None.
stuff like that.
Yeah, none. That's the nice thing about it. Now, some people get a little sore throat. It's a little bit of a bigger probe. That sore throat seldom lasts more than a few hours. And so patients usually just wake up groggy from the sedation, and then they're good to go in a couple of hours. The whole test itself takes about 15 minutes. So it's a pretty short procedure that gets a lot of information, accurate information in a short period of time, and again, allows for doctors to take biopsies.
But the pancreas is, in diameter, it's relatively small. compared to the length, right? It's an oblong element.
It is, yeah, it's sort of a longer, right? it's
So, but
like-
can't the tumor, it can be anywhere along the full length. So do you ever have to take multiple punctures through the stomach in order, I mean, if you just check one spot,
Yeah,
well, the cancer or the tumor may be at the other end of the pancreas, right?
it sure can be.
So, I mean, you can, or
Oh,
often you
yeah.
have to take multiple punctures.
Yeah, so whenever the nice thing is we see where the tumor is. So we first inspect the whole pancreas from head to tail, and we see where there's spots. If there's a spot in the head and in the tail, we can do 2 separate biopsies in each of those areas.
Well, and you're telling the location of the tumor by
By the way it looks?
CT scan or?
Nope, by the ultrasound.
Yeah,
The
but in order
ultrasound
to
shows it.
get this, you have to penetrate through the stomach wall, no?
Exactly. Yeah, so when we're having the ultrasound probe down there, when this probe is down there, that's what I'm doing, is I'm looking around, I'm inspecting the whole pancreas. And we can see with our own eyes a growth. We can
Okay.
see a lump. We can see a growth
Well,
down there.
typically, how many penetrations do you have to make through the stomach wall?
In general, roughly about 4, it varies. But what we do is when we stick the needle in, we get some tissue and we get that tissue and we give it to a pathologist who's in the room. So we have a pathology physician come to the room and we give them the tissue right there. They put it under the microscope in the room. And then they say, hey, doc, we got it. Or they say, hey, doc, I need some more samples. And we take some more samples until the pathologist gives me the thumbs up. That means we're done. And so the nice thing about it too, in many places, such as over at Christ, when we do this, we get real-time confirmation from a pathologist that we have enough tissue to make a diagnosis. So sometimes I'm able to tell my patients right away, at the end of the procedure, if we're concerned about
And
cancer.
along the full length, is it typical that the tumor is typically at one end as opposed to the other end?
Yeah, it's usually going to be on just one end. In some advanced cancers, it can involve both ends or have 2 separate sites.
Okay.
So with this test,
Mhm.
you can see smaller masses than
Exactly.
you can with the previous scans.
Exactly. You can pick up things up to even 2 millimeters in size. And that's even getting even better. We have some newer technologies called elastography and contrast enhanced endoscopic ultrasound where we're even able to pick up even in higher accuracy, smaller tumors. And so when I do an exam with an endoscopic ultrasound and I don't see any cancer, I feel really comfortable that this is, clear. And so it's a nice test, gives us answers very quickly. And the other advantage of this endoscopic ultrasound is that when we're down there taking biopsies and diagnosing the tumor, we're also looking to see if it's spread to any of the areas around it. And so that's part of what's called staging. So between the CT, the MRI, and the endoscopic ultrasound, those are the big tests that you're going to get and the main tests that you're going to get to make a diagnosis. A big question that always comes up, and this is kind of the holy grail of cancer, treatment in general, is there a blood test, doc? Is there just some blood test that I can get that'll tell me if I have pancreatic cancer, if I'm at high risk of cancer? And unfortunately, we don't have a very good or very accurate one. There's a lot of studies and a lot of money going into that. But right now, the only blood test we have is something called a cancer antigen 19-9, CA19-9. That's a blood test that is a tumor marker for pancreatic cancer, and it can be elevated if you have pancreatic cancer. The only problem is about 15% of patients with pancreatic cancer don't have an elevated CA19-9, so it's not perfect, okay? So we don't use it for screening. We don't just say, okay, I'm here at my routine physical with my primary doctor. You're going to check my basic labs. Why don't you slap on a CA19-9? It's not used in that setting, and it's not accurate enough in that setting for screening, unfortunately. So we will only get this test done if you have another scan that shows a little something in your pancreas. We get this, and if it's high, that strengthens the probability that we're dealing with pancreatic cancer. So once we've diagnosed the pancreatic cancer, the first question that always comes up is, well, okay, what stage is it? So you guys have probably heard the term staging of cancer. Staging of cancer essentially is when we determine how advanced the cancer is. Every cancer has a stage. The lower the stage, means smaller or the more contained that it is, whereas the more advanced the stage means, or the higher the stage means it's more advanced and spread. And so you hear stages 1 through 4. Stage 4 usually means metastatic, means it's spread, whereas stage 1 usually means it's contained at its site of origin. And so once we've diagnosed pancreatic cancer, we need to determine the stage. And so the stage has a lot to do with size, okay? So first of all, the smaller the tumor in general, the better. And I'll go over here in just a second here. Why is that stage important? Well, for two things. One, it tells us what's the best treatment, and I'll show that in the next slide. But two, it also gives us a prognosis. Prognosis means what's the expectation of survival? How are we going to do? And so patients that have early stage, like we talked about on that earlier slide, they do better. They have more treatment options and their outcomes are better. And so the stage determines how well you're going to do, with likelihood of you doing well as what treatment options are available. So the first thing your doctor is going to want to know, and every patient is going to want to know, when we stage, what the stage is, we want to ask ourselves, is this something that can be cut out? Okay, is this cancer that is just in the pancreas that we can cut it out, just have a surgery? So resectable means removable surgically, okay? Unresectable, which is on the opposite end of the spectrum, refers to cancers that have spread beyond the pancreas, where going in and just cutting out the tumor in the pancreas has no benefit because the cancer is still there. It's at other sites. Borderline resectable means it hasn't spread anywhere far, but it's still a little too advanced to just cut out. And let's talk about that. Okay, so resectable is right now, so a cancer that is able to be cut out or removed right now is the only known cure for pancreatic cancer. So anybody who's getting any other treatment other than surgery, right now, those treatments are not under what we call curative intent most of the time. So for a cancer to be curative, surgery remains the main option, the main treatment. For people who have a cancer that's an early stage that can be cut out, those are the patients that we are deeming potentially curable, okay? For patients that have a cancer that may be a little bit too big to be cut out, those are patients that we try and shrink the cancer first using things like radiation therapy or chemotherapy to shrink it, and then go to surgery, okay? So those people can still achieve cure, but the rate of people that are getting cured who fall under that category is smaller. For people that have metastatic cancer or advanced cancer, they get what's called palliative chemotherapy, which means chemotherapy that is meant to prolong their life as much as possible without probability for cure. So it's meant to give you some additional months or hopefully additional years, and we'll look at those numbers here. But let me pause there. Does that make sense kind of when we're talking about, say, yeah, go ahead.
If it's small enough, when you're doing your initial check and you find a small spot on your procedure and you do that biopsy, does a biopsy count as a surgery?
Well, that's a good question. I wish that we had an ability to, through the scope, pluck it out, or like we would say, like a colon polyp or something like that, or even, you know, use some kind of ablation technique with the needle. Unfortunately, even the smallest tumor, the only treatment is the surgery. And I'm going to jump ahead to show what those surgeries are, and then we'll kind of go back up to talk about this kind of category right here, this borderline resectable. Because these are important, I think, because when patients are getting diagnosed, they're being kind of put into these categories, and sometimes they get confused. Well, doc, why can't I just go for surgery? Or doc, why am I getting chemo? And these categories that they're put into sort of explains that. But the surgery that we use for pancreatic cancer depends on where in the pancreas the cancer is present. So if the cancer is in the head of the pancreas, you get a surgery called a Whipple procedure. Is anybody familiar with a Whipple surgery? Yeah, so the Whipple surgery is a very big surgery. It's probably one of the biggest surgeries out there because the pancreas head is in a very busy area. In order to take out the head of the pancreas, they have to cut out part of your small intestine. They have to cut out the bile duct. They have to cut out the head of the pancreas. They have to cut out your intestine here and then reattach everything. So after the end of the surgery, your stomach is attached to a part of your small bowel that's called the jejunum, which they've brought up. And then the other half of your pancreas is then attached to the intestine. Your bile duct coming out of your liver has to get sewn into your intestine. And so all that's done during a procedure. Historically, this procedure back in the 70s had a 30% chance of dying. Okay, so back when it first came out, this was a really, really very morbid surgery, and patients had a big chance of not making it off the operating table. Fast forward to 2023, we're a lot better. We're doing much, much better with these Whipple procedures, where we now have a risk of death in many high volume institutions of 1 to 3%. And these are now being offered laparoscopically, just like you can have a laparoscopic gallbladder removal where you only have 3 or 4 small ports, or even robotic. Okay, so we've come a long way. And the emphasis here, and the most important thing and a real big point to take home, is that this low mortality, this good outcome, really depends on the volume of the center. So this is not a surgery that is done by a general surgeon who doesn't do these on a frequent basis. The more that your surgeon does, the more experienced your surgeon is, the better the outcomes. And this has been shown consistently over and over and over again in many studies. So this is where you want an experienced surgeon. Over at Advocate Christ, we have Dr. Mesla, who's a very skilled pancreatic biliary surgeon who does an exceptionally high volume of these procedures. And the outcomes are in this category here, patients doing very well. So this is not a surgery if you have a family member who may be in the middle of nowhere, that's the sort of person that you want to say, hey, come on down, let's get you somewhere where there's high volume, because you don't want to mess around with this type of surgery in unexperienced hands. And I'm very particular where I send my patients to for this procedure because, of the outcomes. Yep.
So in the previous slide,
Mhm.
you just don't go in and cut the part out and you're done.
Yeah.
You gotta do all this other stuff.
You gotta do all the stuff. You can't enucleate it when you just take out the part.
Right.
I wish that was the case. So that the reason these surgeries are more advanced is you have to take out the tumor, but you also have to take out some surrounding tissue because, for what's called micrometastases, sometimes the tumor kind of spreads on a microscopic level. You have to take the lymph nodes, which drain that area, and the vessels that sort of feed that area. And because the pancreas is essentially attached to the small intestine, you got to yank out part of that small intestine and the ducts. That's what makes it such a complicated surgery.
And what about if it's on the tail end?
Thank you. So if it's on the tail end, you get what's called distal pancreatectomy. That's a much easier surgery, still a challenging surgery, but that guy, they just need to snip out the tail of your pancreas, okay? A lot of times they will take the spleen with it, okay? But that does not require all that extensive reconstruction because it's a less busy area. Unfortunately, there's less connections there. So it's an easier surgery. Unfortunately, most patients who have a cancer in the tail of the pancreas, they tend to already have advanced disease because when it's in the tail of the pancreas, it tends to be much more silent. It doesn't cause symptoms until later on because it doesn't block some of these ducts that cause the symptoms that bring you to your doctor's attention.
So you don't have the symptoms as much.
You don't have the symptoms until it's too late. So that's why it's very infrequent that we're fortunate enough to have a patient who has a tail of the pancreas tumor that's actually treatable with surgery where we're picking it up early. Those are the ones, I had one last week. He came in because he had, he fell down, hurt his back. They got a scan and they found that he has a very small tumor in the tail of the pancreas. We did the endoscopic ultrasound biopsy. It was positive. He had no lymph nodes. We said, guys, let's move on this. He got a surgery and actually did really well. His lymph nodes were all negative and he had no spread. So sometimes we're very happy. But those are the two main surgery types you're going to get for pancreatic cancer. Okay.
Can you go over the morbidity? What, on that
Yeah.
right there, what is that?
Those are like the risks. So we talked, mortality means the risk of death, right? Which is low now, but what about the risk of side effects or complications? Those are still a big deal. So maybe about 20% of patients might have, some kind of complication, which means that after the surgery, they have some issue. The biggest issue that you can get is something called delayed stomach emptying, where your stomach just doesn't empty as quickly as it would normally. And that can make you feel nauseous and get full early. And that's usually something that we can fix with some medications. Other sort of symptoms or risks are something called a pancreatic fistula. That means you kind of leak pancreatic juice, where that duct is. Sometimes you can leak where they kind of stitched it, it can leak out. And then you can get infections and bleeding just like with any other surgery.
Now, with these symptoms that you're mentioning at the bottom,
Yeah,
does that happen quickly or over time?
these are, the bleeding and the infections, those happen within the first, 1 to 2 weeks. The delayed emptying can occur within the first couple of months.
Couple months.
Yeah, and a lot of that has to do because they have to snip one of the nerves that is responsible for kind of emptying of the stomach in part, and so that plays a role there. Okay, so what about the chemotherapy? So the chemotherapy for pancreatic cancer is evolving, okay? In most cases, for patients who get diagnosed with pancreatic cancer, if it's very small, like I said, they'll go to surgery up front. If it's kind of big, but hasn't spread, they will get what's called neoadjuvant chemotherapy. That means chemotherapy before surgery. And that chemotherapy is meant to debulk or downgrade the stage of the cancer. And so those are patients that might get chemotherapy and sometimes radiation first, and then go to surgery. After any pancreatic cancer treatment, regardless of the stage, you will always need chemotherapy after the surgery. So that's called adjuvant chemotherapy. So some people get chemotherapy before surgery, and some people then go on to surgery, and then everybody will also get chemotherapy after the surgery.
So they have it twice.
So they have it twice in many situations, right? There's different agents that we use. Let me jump to this one real fast first. So this chart here sort of shows throughout the decades the different chemotherapy agents that have been used for pancreatic cancer and how effective they are. Because this is a survival plot here, and so the higher that little, that graph, the better the survival is for patients. So we used to use gemcitabine alone, that's a chemotherapy agent, and now we're, for patients that are healthy enough, we're using something called FOLFIRINOX, which is a more aggressive type of a chemotherapy, and it's used in some other cancers as well. You have to be relatively functional for some of these chemotherapies. So when you're diagnosed, or if someone is diagnosed with pancreatic cancer, they're going to meet a couple of physicians. First of all, it's usually the gastroenterologist like myself, where we get a diagnosis and help with the stage. Then they're going to meet the pancreatic surgeon and the oncologist, and then sometimes a radiation oncologist. So there's a lot of specialists involved. But that oncologist, the cancer doctor, is going to ask you questions like how many flights of stairs can you go up? Are you doing any lifting? How active are you? Are you driving? That's looking for what's called your functional status, because they want to see if you can tolerate getting some strong chemo. And if that's the case, you'll probably get offered, one of the more aggressive chemo regimens called FOLFIRINOX.
Now, these therapies, how long do they give? How long do they give it? Forever? Rest of your life?
No, so they're usually given in cycles, and at the end of the cycle, and that varies, sometimes it's 6 weeks or longer, depending on the oncologist's discretion and what kind they're using. They will rescan and see if it's working. If it's working, then they'll probably either continue it. So if you see it's smaller, they might then give you another course. If they see that it's not working at all, obviously they'll stop and try a second line therapy. Okay, but these are not sort of like some breast cancer chemo agents that are, taken lifelong. These are meant to be just treatment cycles and courses to see if they work. Okay, does that make sense?
Yeah.
When you are giving chemotherapy,
Mhm.
you are able, how does it affect your daily activities and, activities in that?
Yeah, I mean, every chemo is different. A lot of us have the image of chemotherapy, of sort of losing our hair and, being sick all the time and things like that. And that doesn't necessarily apply to every patient and every chemotherapeutic agent. In general, for example, the gemcitabine that, many patients with pancreatic cancer get, it's actually relatively well tolerated. As you get, into some of the FOLFIRINOX and other chemotherapeutic agents, the patients will feel, a lot of times run down. They'll have malaise and fatigue and sometimes decreased appetite. Sometimes patients have more pronounced side effects, like they are dropping their immune cells very quickly and getting sick. And so in general, you will feel a difference while you're on chemotherapy, but the amount of discomfort varies from patient to patient. It's not as, say, some chemotherapies for like leukemia and things like that, which have a much heavier toll a lot of times on patients. These tend to be a little bit more well tolerated, but again, that's why your functional status is really important, meaning how strong you are going into it, you're going to tolerate it better and be able to complete the treatment. Many patients have to stop.
What is a PDAC?
Sorry, yeah, I should have changed that abbreviation. That's just pancreatic cancer. Pancreatic ductal adenocarcinoma is the official name for pancreatic cancer. So on this slide, I just didn't change it. But yeah, sorry, that's pancreatic ductal adenocarcinoma. It's much easier to just say pancreatic cancer. Okay, these graphs are just kind of showing that for patients who have advanced disease, who get chemotherapy, so patients that are not treatable with surgery, who are getting chemotherapy for palliation, meaning to try and prolong their life. How are we doing? Well, these newer agents, on average, we're getting now survival probability of about a year. We're getting patients out to about a year with chemotherapy. So if you're diagnosed with metastatic or stage 4 pancreatic cancer, more than half of those patients are going to, with most aggressive chemotherapy, are going to pass. Whereas we're getting patients, roughly, past that 3 to 6 month mark. We're starting to get our patients up above a year in terms of survival for our sickest of patients. So these are our most advanced patients with pancreatic cancer who are just getting chemotherapy. So we have a lot of room to go on this, and this is where the future is, which is, instead of just giving the same chemotherapy for everybody, is trying to detect any sort of mutations in everyone's cancer and tailor that treatment to be specific to your cancer, because not every cancer is the same. One person's pancreatic cancer may be very different from another person's pancreatic cancer on a molecular level. And so if we can analyze the molecular structure of everyone's cancer and pick therapy that targets that particular mutation, that's going to give us better outcomes. And that's looked at for all cancers, and pancreatic cancer, that's particularly of interest. And that's, I think, the future. So when we're taking these biopsies to get a diagnosis, we're sending them out to these gene labs where they're looking at all the genes and looking for mutations. And that can help your oncologist potentially say, hey, you may be a candidate for an investigational drug or for, a different type of immunotherapy. And I think that's very exciting. And I think there's more to come on that. Right now, it's still not mainstream, but this is where a lot of our progress is being made, which is adding additional therapies based on what mutation you have. Okay, I want to make sure I don't run over. So I'm going to kind of go over this screening real fast. And then we'll talk a little bit about some of the scopes that we do for patients. But can I get 5 more minutes, you think? Is that enough? Okay. All right. So because we talked about just how lethal pancreatic cancer is and the fact that it's picked up very late, are there any things that we can do to try and pick it up early, meaning before any symptoms develop? Just like colon cancer, all of us at the age of 45 or 50 should get a colonoscopy or get screening for colon cancer every 10 years, even if we're feeling great. Can we do something like that for pancreatic cancer? Well, unfortunately, because they've looked at it, and it's not recommended to just screen everybody, meaning everybody in the population as part of their annual, get screened for pancreatic cancer. The benefit for screening should be for only patients that are at the highest risk for pancreatic cancer. And so we'll talk about now just who are those patients that are at the highest risk for pancreatic cancer. So the one that I want to really point out here is familial. Okay, so most pancreatic cancers, they're sporadic, meaning they happen even if you don't have a family member who's got it. Okay, it's just a mutation that occurs and causing the cancer to occur. But in 5 to 10% of people, it clusters in families. So anybody who has a family history of pancreatic cancer, especially a first-degree family member, especially if you have more than one family member, those patients have a much higher risk of developing pancreatic cancer themselves. And those are patients that should approach their doctor about potential screening. And we have screening tests and screening programs that we can enroll patients in, where we will sequentially or periodically look at their pancreas with either that scope or a CT scan every several years to make sure that we're not developing pancreatic cancer. So if you look at the bottom of this, this chart here, familial pancreatic cancer, meaning someone who has 2 or more first-degree family members with pancreatic cancer. Let's say you have a sibling and a parent. You have up to a 32-fold higher chance of developing pancreatic cancer yourself. And so that's an example of someone who should be seen in a screening program. And I'll talk about that here real fast. If you have 1 first-degree family member and then maybe a 2nd degree or 2 2nd-degree family members, so an aunt, an uncle, or a cousin, your risk does go up, but it's not as high. Okay, so the more first-degree family members you have, the higher the risk, but the more family members in general with pancreatic cancer still increases your risk, and you still qualify for high-risk screening. These are just mutations. So there are some genetic mutations that predispose to other things. Many of us are familiar with the BRCA mutations for breast cancer, BRCA1, BRCA2. Those mutations also can increase your risk of pancreatic cancer. So for patients that have those, we can also screen them. And these are just some other mutations that we won't go into for the sake of time. But what happens is if you have that family history, if you have any of those mutations in the family, you can see a genetic cancer risk assessment program. And we actually have one here at Advocate Christ, where we have a certified genetic counselor, an oncologist, interventional gastroenterologist, which is myself, and a pancreatic surgeon who are part of this program. And essentially you'll get plugged in. They will ask you detailed history about your family members with pancreatic cancer, how old were they, all that. And then they may offer you blood tests to test for genetic conditions that will increase your risk for pancreatic cancer. And then potentially enroll you in surveillance. So a program where they say every year, we're gonna do a CT scan, or every other year, we're gonna do an endoscopic ultrasound, and they follow you. And this is now gaining a lot of traction and is a good way that we may be able to start picking up pancreatic cancer a little bit earlier in that subset of patients who are at high risk. The other risk factors, if you smoke, don't. Okay, smoking, can increase your risk of many cancers, but pancreas is particularly susceptible to cigarette smoking. Greater than 3 alcoholic drinks per day also increases your risk of pancreatic cancer. If you get pancreatitis that we talked about earlier, if you're obese, if you have a BMI greater than 40, and then like I talked about, if you have diabetes, these are some of the risk factors. Some of these are environmental, meaning you can modify, like the drinking and the cigarette smoking. And so decreasing those improves your likelihood of not getting pancreatic cancer. All right, so kind of finally here, I'm going to skip one little thing over here. Okay, so one of the most important things, since most of our patients with pancreatic cancer are going to have advanced disease, these patients can be very sick. They can have a very, very challenging quality of life. They're in a lot of pain. They can't eat. They're turning yellow. They're very sad. They are malnourished. These patients can suffer. And so part of our goals, in addition to trying to find a cure, is doing anything we can to give them comfort, anything we can to improve their quality of life. And sometimes that's more important than a cure. When you have a
Are you talking about, is that in regards to the surgery, or is that just before the, like before you get diagnosed, you could have these complications?
Oh, no, I'm talking about all patients with pancreatic cancer, but especially pancreatic cancer that's advanced. So patients that aren't going to get a surgery because their cancer is too far. These patients, have a potentially limited time with us. And so we want to improve that time that they have so we can spend it with their family, with their loved ones, and rather than spending it sort of suffering. And so for those patients where there's a lot of things that we can deal with the scope endoscopically that can help alleviate their issues. So for example, the jaundice that we talked about, we can actually go in with the scope and put a stent. I put a little stent into that bile duct and prop it open so that the bile can drain. It pushes away the cancer so the bile can drain through there. So that's one thing that we can do to alleviate their jaundice and their obstruction and allow them to potentially feel a little bit better. That's done with the scope as an outpatient basis. It takes about 20 minutes. We use different kinds of stents. We have metallic stents that last a little bit longer. We have plastic stents. These prop open that bile duct. This is an X-ray showing a metal stent inside the bile duct. And now bile can flow from the liver through this stent into your intestine and help you digest. And this is this is what it looks like on the scope side. So for people who are jaundiced, we have things that can help them. The other thing that can get blocked is because the pancreas head is very close to the small intestine, sometimes the tumor grows so large that it blocks your intestine, and now your food has nowhere to go. That's called a gastric outlet obstruction. So they try and eat, but the food has nowhere to go, so they vomit it up. It's a horrific symptom. Their stomach inflates like a balloon because they can't drain. And what we can do for those patients is one of two things. One, there's a surgery that they can do, kind of like a bypass. But now, more often these days, we're using a scope to put a stent into that small intestine, just like we're putting a stent into their bile duct to prop it open. We can put a stent into their small bowel to prop it open so that food can get through. Okay, that's also about a 20-minute procedure done endoscopically. These are things that can help improve your quality of life. Okay. And then for the pain, this pain is present because we have something called the celiac plexus behind our pancreas, and that can be very painful. Those nerves get involved. So we inject something into those nerves directly using a scope. We can take that endoscopic ultrasound scope down, find those nerves, and inject some alcohol and some lidocaine in there and just ablate the nerves. to improve pain for our patients. So these are some examples of things that we can do with the scope to help our patients deal with some of the symptoms of pancreatic cancer. So I'm going to sort of end right there, for the sake of time. And just as a summary, pancreatic cancer is increasing in its incidence. It's getting a lot more put in the spotlight. Our mortality is going up, and we have a lot of work to do on improving some of our outcomes for our patients. And we are going to start making progress with some of our chemotherapeutic agents, some of our newer molecular analysis, and our immunotherapy. We are going to start making some dents that I think we're going to start to see very soon. With our newer scopes, we're picking it up potentially a little bit earlier or smaller and able to diagnose it more accurately. And as we get better at finding patients who are at higher risk, I think we're going to be even better at picking up early cancers.
Any comparison of men to women in the frequency of pancreatic cancer?
It's more common in men. It is more common in men, but not drastically. Yeah, but men, it is more common. It's more common in African Americans, more common in men. It's more common above the age of 65.
I just have a comment from online. Somebody says, my father and first cousin both died from pancreatic cancer, and I have two sisters that had breast cancer, and one sister died from ovarian cancer. That's just the comment.
Yeah, so that's a very significant family history. That family history raises the spectrum of the possibility of an underlying genetic predisposition, for example, Lynch syndrome, or maybe even a BRCA mutation. And that would be somebody that would really benefit from talking to a genetic counselor. It's very helpful for family members of patients who have that sort of a pedigree to sit with a genetics counselor and potentially talk about genetic testing and potentially screening modalities. So that does fall into the category of being elevated risk, especially for those breast cancer patients or BRCA, BRCA1 or BRCA2 positive. So that would be something to definitely bring up, with your primary doctor or with a gastroenterologist to get plugged in for screening. So complications are common with pancreatic cancer. We're doing a better job of keeping patients comfortable during that time. So if we have to breeze through a lot of stuff, and I think I talk a lot and I tend to, drag things on. So I don't want to keep you guys here later than you already are. If I didn't cover anything, if there's a burning question, fire away. You also have my email address right here, my office number. My office is just down here on 105th and Cicero. Been here now for almost 10 years. And we're doing a lot of pancreatic cancer care over at Christ down the street as well. And that's where a lot of our cancer screening programs are, as well as our pancreatic biliary surgeons. Feel free to email me any questions, call me if you have any issues. I'm happy to also see you in the office if you have any particular, concerns in terms of, your health or symptoms that you might be worried about. But I want to thank you guys all for coming.
I'm listening to you speak, but I'm not getting a warm, touchy feeling.
Okay. Pancreatic cancer is serious.
Yeah. It's kind of like,
It's
oh,
scary.
there's a lot of touchy feely stuff. Let's try this and try that. It's kind of scary.
It is. Yeah, it is. And I wish I had better sort of numbers to show you, but I think that's part of where the importance of a talk like this comes in, is as we raise more awareness in the population about this cancer, about some of the symptoms, it helps us, bring things to light a lot earlier. And it also helps us kind of feel with or understand our family members or our friends who do have pancreatic cancer. But I agree with you. I hope that next year or the year after, when I give this talk, there'll be a little bit more touchy feelings where I can say, hey, look at this, we got numbers in that, upper percentile. And I think that's doable. That is doable.
Is there such a thing? I'm sorry, go ahead. Are there such a thing as clusters?
What do you mean?
Well, okay, you know that he has pancreatic cancer because
Mhm.
he's his gastroenterologist, kind of. He put his stint in. I'm talking out of too much information right there, but anyway, there was a girl that went to our class, in our class, that died of pancreatic cancer just recently. So, so is there a possibility that there might be a, you know, like how you have breast cancer clusters?
I see what you're saying. So sort of like an environmental cluster, say, you know, a group of people who live in the same area or, you know, and nothing that we've been able to pan out. I mean, it's a good question. We always wonder about that, you know, like, for example, Agent Orange or, you know, things like that, people that were exposed to all then, you know, a big fraction developed, you know, certain types of cancer. Nothing from a pancreatic cancer standpoint where we've really been able to highlight sort of like an environmental cluster effect that I'm aware of. It's usually 90% of these are sporadic, meaning it's a mutation that occurs in the cells of your pancreas that trigger it to grow or proliferate unregulated and then sort of spread. And so about, again, 80% of our patients is that mutation occurs. And what turns on that mutation, you know, that's still, you know, what we're trying to discern.
Are you doing any studies on it though?
Me personally, no, but there are tremendous amounts of studies going on and a lot of money, you know, from the NIH and other institutions trying to better understand the physiology of pancreatic cancer. The studies that I'm involved in are looking at patients that have potential precursor lesions to pancreatic cancer. I didn't talk about that for the sake of time, but that is pancreatic cysts. So cysts of the pancreas. Yeah, so one potential precursor for pancreatic cancer is a pancreatic cyst. Some pancreatic cysts can transform into pancreatic cancer. And cysts are collections of fluid in the pancreas. Some of those have a chance to turn into cancer. And so if we can find patients who have those cysts and watch them and potentially maybe even treat them before it turns into cancer, that's something that we may be able to make a big dent in.
Because that's what I was gonna ask, because for about last 10 years, I've been having MRI,
Thanks for coming.
just about every year.
Say that again, I'm sorry.
For the last 10 years, I was having MRIs, just to check on the status of the cyst, whether they were changing. And the last one I had, it was 10 or 11 years.
Okay.
They basically said nothing's changed in the last 10 years, so you find the work and you know, you don't need to do it more. What I'm wondering is, would it be wise to request an MRI that's in 5 years to make sure nothing's changed in that time span?
Yeah, so it depends on the kind of cyst. So anybody who has a
And I
cyst,
can't remember which kind it was.
yeah, so, you know, because there's two kinds of cysts. You know, this diagram here, and again, I apologize that I didn't talk about this during the talk. There's cysts that are called mucinous cysts, and there's non-mucinous cysts. Mucinous cysts of the pancreas can turn into cancer, whereas non-mucinous cysts don't turn into cancer. So when you have a cyst of the pancreas, your doctor needs to get you plugged in with a gastroenterologist to see which of these two you have. And they usually do that either by the way it looks on the ultrasound or by sticking a needle into the fluid and sending it to a lab. If you did have this mucinous cyst, then you will get, usually depending on the size, you'll get a scan maybe every 1 or 2 years to make sure it's not growing or trying to transform into cancer. And after a set number of years of no change, many experts will recommend that we leave you alone, but we're not quite sure what that duration is. Some people say 5 years of no change, but many people disagree with that and think somewhere over to 10 years of no change. So I would say in your case, it's probably best if it hasn't been looked at in a long time.
Well, the last one was just 2 weeks ago, whatever. And
Okay.
that's when they said it's been 10 years, nothing changed.
Good.
So you know, you're fine. What I was wondering is, as a precaution, because for some reason pancreatic cancer to me is probably one of the worst.
Mhm.
And maybe because of what you hear, but I mean, no cancer is nice anyway, but I was wondering, since now this, I don't know, just been dealing with my primary physician, if I should ask her in 5 years from now, should we do another MRI, just to make sure nothing's changed?
Yeah, I mean, I can say 10 years of no growth is very reassuring. That is a very good sign. I think a lot of it, do you know how big your cyst is?
No.
No, so if
They
it's.
probably told me at one time, but
Sure.
I had other things to deal with.
Yeah, I don't.
Because mine came out by accident, I
As
was
most people do.
diagnosed with Crohn's disease, and then they took, I can't remember what test I had, it wasn't a colonoscopy.
Mhm.
And they said, well, there's something there that needs to be checked further, you need an endoscopy.
Yeah, that's how most of these are picked up, are kind of incidental.
Yeah.
So, I would say, if it's less than a centimeter in size and it's been stable over 10 years, you probably don't need another test. But I find a lot of benefit sometimes to just reassurance. If I'm anxious over something, sometimes making sure I'm looking at it in one way or the other gives me peace of mind. So, I think it's not unreasonable for you to have another look, but I probably wouldn't do it yearly.
Right,
I would say that.
like I said, 5 years, I figured, well,
That's
maybe 5
reasonable.
years, I could wait and just in case something changes.
Yeah, I mean, again, it depends on the details of your cyst, but, that's definitely something that does not seem unreasonable to do.
I wanted to ask you earlier, when you were talking about radiation,
Mhm.
can radiation be a risk for future,
Issues?
can be a cause for recurrence? And also, can you tell from any of the scans if there's any damage from previous radiation?
Mhm. Yeah, so radiation can have some effects on the body. There's different kinds of radiation. The more sort of focused the radiation is just on the tumor itself, the less likely you are to get some potential effects of the radiation beam on surrounding issues like your intestine and things like that. So radiation, not to my knowledge, do I know of it increasing the risk of any particular, pancreatic cancers itself, like
Any reoccurrence on any of the other organs, or would it show up like scar tissue or something like that?
yeah,
on
you
the
can
scan?
definitely get radiation, so for example, radiation enteritis, which is small bowel radiation damage that leads to scarring and sort of inflammatory change. You can definitely get something like that with radiation. It depends on how strong the radiation is, what kind of, how focused it is and how long you're getting it.
Okay, and then if you've had radiation in that area,
Mhm.
then can you get radiation again at some point in the future, or?
That's a good question. I don't know the answer to that. I don't know. I think a lot of it has to do with if you got an initial response. My understanding, in my experience, a patient who's got radiation, who achieved radiation therapy for pancreatic cancer, I have not seen them get another treatment,
I mean, how you get radiation, it's in that area, so
Mm-hmm.
if you had radiation in that area, then you get cancer in another organ or recurrence or an organ nearby where you
Yeah.
had that radiation.
Yeah,
I know a long time ago, they said, once you've had radiation, you can't do it again. Is that still
yeah,
the
that's a
case?
good question. I'll be honest, I don't know the answer to that. I can look that up, or I can talk to some of my radiation oncology colleagues, but I don't know if having prior radiation, I think you're right. I think, that may preclude your ability to get radiation, but I'm sure there's more involved, like how long apart the radiation was, but I don't know the right answer to that or an accurate one. But I can circle back with you on that.
And then I have one other one that's
Mhm.
probably more simple.
Mhm.
I hear all the time about a lot of these things are connected with obesity.
Mhm.
But also it circulates a lot about all the toxins in our environment, in our food, and
Mhm.
the soil the food grows in, and so on.
Mhm.
So if you're obese, in theory, you're consuming more food, and in other words, in theory, consuming more toxins that are stored in your fats or whatever. So is the obesity more just being obese in of itself, or do you think it's more because of the toxins, you're getting a higher level of
Yeah,
toxins in your diet that might be causing this?
right. I think it's a little bit more complicated in the sense where I think there's a couple of factors. The presence of obesity itself, I think, does impart some changes on a hormonal level and enzymatic level that, and a pro-inflammatory level that increases the likelihood of cancers. And I think the diet is definitely something that is playing additional roles. It's very well established now that our highly processed foods, so our refined sugars, our processed meats, are very pro-inflammatory and very pro-carcinogenic, meaning, likely to induce cancer. And that's why our World Health Organization has actually labeled those foods as, grade A carcinogens, which are cancer-forming foods. So those definitely, I think, can be playing a role in addition to the obesity factor itself. So in addition to trying, working on obesity, working on the diet as well, and watching what we eat and how we eat is very important. But we still need better guidance. We need better studies to help really tell us, help us pinpoint that.
So the simple version of that is just being too heavy in of itself is a separate factor. that's-
Exactly, yes. We've
Okay.
definitely seen that. The BMI, which is
Okay.
the weight itself, is an independent risk factor for
Okay.
pancreatic cancer.
Is pancreatic cancer more prevalent in certain regions of the world because of the diets, like
Mhm.
Eastern Europe, sausages and all that are really big?
Yeah.
See that as such?
Yeah, it's interesting. Yeah, there are some areas of the world that have certain cancers are higher incidence. So a good example of that is stomach cancer. Stomach cancer, we see a lot more of it in, East Asia and over in sort of the eastern side of Asia because of some changes or some differences in dietary nitrates and how they process foods. And so with pancreatic cancer, there aren't any huge cluster spikes that I'm aware of regions that are much higher in pancreatic cancer. The US is definitely up there. And so, we're on the sort of that chart, but I don't see an area where there's a massive spike above others. Any questions? All right, I hope that was helpful. Like I said, if there's any questions, please shoot me an email. All right, guys, thanks again for coming.
Thank you.
You can tell they're very educated people.